all of them really vertical. They are not. Most of the teeth has a certain inclination, and we need to keep that in mind. Today, we have plethora of instrumentation which can help you with that. And the last, I'm going through this fast because you have gone through this in the lecture previous one, is the golden proportion. Golden proportion has been very popular, still very, very popular, and I hear many speakers, I hear many people still following it. There was a time when I was following golden proportion, which is a fixed one. There is a concept what we call as red proportion, recurring aesthetic dental proportion, which is not fixed but individualized for every patient. We cannot go into detail here, lack of time there. So let's come back to the work. When I'm doing all this, when I have to apply all these principles into creating good restoration, I need to understand the material. You can use any composite system. You can use any composite from any company, from any system, as long as you can get at least these 4 basic kind of composites, where is body dentine, which is opaque, more chrome, with a lot of chroma, less value. You can use enamel, which has higher value, that is lighter, less chroma, translucent. Then you can use special enamel composites, which are translucent and semi-translucent. So we'll see how I use them. The cases that I'm going to show now are based on these systems. I have used composites, which are Tetric and Ceram, Empress Direct, bulk fill. The adhesive that I've used is Tetric and Bond self-etch, adhese SE. This is Tetric and Ceram, which is a universal composite in my practice. I do probably all my work with this one. It's a nano composite, universal in application, have all dentine and enamel shades, have a lot of translucent and flow shades. When I have to do high-end aesthetic work and patient can afford it, because this is expensive, I use IPS Empress Direct. Believe me, if any one of you would end up using this, you will never go back to any other composite to work with it. That's have been my experience. It has multiple shades, so many that there's no situation where you cannot cover it. It's extremely translucent clinically, extremely opaque, radio-opaquely, and beautifully polishable. So once I have to use this, there is a very small, I don't want to go into detail here. Last evening we were discussing this in a lot of detail in the hands-on, is the predictable bonding. Bonding has been, and now thanks to the composite told by Dr. Rumpa, I think we will get rid of this step soon enough. But bonding, all of you who are still using bonding, you need to understand that there is a technique of using bonding. We don't apply bond, we scrub bond. Before bonding, we need to clean the cavity. There are times when we etch the cavity. If we are etching the enamel, or even if you're sometimes etching dentin, you need to clean that etchant, and it requires at least 15 seconds of air-water spray to completely clean or wash away etchant. If you're doing anything less than that, you are leaving residual etchant on your surfaces, and then you cannot blame the material that it does not have good bond strength, or it has leakage, or it has sensitivity. What is wet bonding? With the technique that I use, I can share with you. I do not dry off the bond with air. I simply, once I've washed out the etchant, I take a filter paper pellet, put it into the cavity, and let it absorb all the fluid. Once it has absorbed all the water, that's what I call as a moist cavity. It's not a wet cavity, it's not a dry cavity, and I have achieved success with that. Depending on what kind of bonding you are using, whether it's acetone-based, ethyl alcohol-based, ethyl alcohol water-based, you need to know that how to apply that and how to blow dry that. So go back, read your bond, see what bonding you are using, because that's one crucial step. You don't want your restorations to debond. And that is one step where I've noticed most of the dentists spend least of the time. We wash, fatafat bond lagaya, and that's done. This is not the right way. So I spend a lot of time on bonding, because today we have bulk materials which helps us to do the filling faster. So I spend time to do a predictable bond. After bonding is curing, once you have placed the material. Now curing is another shady gray area where people are not really aware of. I was not aware of that, and once I started, as I said, when I approach a scenario, I try to equip myself with all the knowledge that is there belonging to that area. So I started reading on curing, and I realized that there's something known as total energy concept. And the total energy concept tells us that if you have to cure composite, 2 millimeters of A2 shade, you require 16,000 joules of energy to completely cure it. Now let's say your light intensity, whichever you are using, I'm taking here as standard the halogen bulb, which probably gives you 400 milliwatt per centimeter square. So you require to cure it for 40 seconds. Though I know 80% of the dentists, if I ask them, they say I cure for 20 seconds. In my whole life, I have not cured for 20 seconds. In my whole life, I have not cured for less than 40 seconds. There have been areas when I cure for more than 60 seconds. Time wastage, I know. So either I improve my light, and you can go to 2000 milliwatts, which you can cure in 10 seconds. But you have to remember that you have to impart to your composite 16,000 joules of energy to achieve proper cure. In later slides, I'll show you studies where they show that if proper cure is not there, proper polymerization is not there, and you have fractured restorations. Shade affects your curing time. 20 seconds, 2 millimeter, 1200 milliwatt is 20 seconds. But if you're using A3, A4, the curing time has to go up because light cannot penetrate more. If you're using opacious dentine shades, you have to cure more because light cannot penetrate that depth. So your curing time goes up. This is the study which shows as the shade goes more and more darker, the curing time goes up. Last is the activator. If you are using multiple composites and if you are using highly aesthetic one, and stay with me, these are the last theory slides. The most common activator is camphorquinone, which is yellow in color. But if I want to create translucent teeth, if I want to create opaque restorations, I cannot use this. So we use opaque material, which is TPO or Leucerin TPO or PPD. The problem with these ones is that they do not have light spectrum. As you notice, they do not have light spectrum in blue light. They have light spectrum in violet light. So you need to have lights which are equipped with violet light and just not ultraviolet, which is the blue light. So when I use a light, now I see that I have a light which covers all my activators. So either I don't use those activators, or if I'm using them, I have the right light. So these are the basic curing principles that you have to keep in mind when you work. This is the light that I use, Blueface C8. It gives me 800 milliwatt per centimeter square, and it covers all the spectrum. These are the materials that I use, some of them which makes my life easy. These are the polishers. And now let's go into the cases. Now I have divided my cases into three parts, which is aesthetic, functional, and functional. Aesthetic cases, I believe you can start aesthetic cases by simple restorations like these, which are class 5s. These are tetric NCERAM restorations, normal class 5s. No, I don't know how it happens here in Bangladesh, but in my country, in Delhi, in my initial years of practice, no patient came in and said, okay, you do veneers for me, okay, you do high-end cosmetic work for me. No, they just came for normal restorations. And I was giving them, trying to do beautiful, even class 5s, and trying to do them nicely so that they have in their mind that this guy knows aesthetics. So you can start off with simple class 4 carious restorations, do them well with average. This is average tetric and ceram composite. This is no high-end composite that I'm using. Cases like this, which have opacious teeth, class 4 restorations, clean them and bring them back to normal using all the principles that I've talked about. When you come into some high-end work, you can actually create restorations which come out much, much beautiful and tooth-like. Let me share a case with you. This was a case who went through central incisor, lateral incisor extraction because of cyst, and she was wearing a partial denture, but she didn't like her central incisor, which had some faulty filling. Now, this kind of a restoration where I'm trying to give her the best of the aesthetics, I use materials like MPS Direct. And this is how I start working. This is the lingual most semi-translucent enamel on which I create my lingual wall. This is how I work with all my interior restorations. I create a lingual wall, and then I start putting dentine with the principles of dentine application. I put enamel with the principles of enamel application, and then I put my translucent enamel. I always overbuild, and then I take my carbide fissure burrs and finish it down. And the final restoration that matches with the tooth is this. So this is the kind of the work that you can achieve. If I can achieve me, trust me, all of you can do that. Because I never started my dentistry with composites. I was always a ceramic guy. So this is the material. From here to there, you can create excellent restorations if you follow all that basic microaesthetics principles in there. Let's look at another case. This is normal, multiple old faulty restorations in patient's mouth. You look at a case, you look at your zenith points. So this is the right central incisor already done. I go to the left one, I look at my zenith points, I look at my height of contours, and then I start off with the next tooth. So that's the next tooth, cleaned, beveled, etched, bonded, and eventually you achieve this. This is again with IPS Empress Direct. It's not just necessary to look at it from the front, you look at it from multiple angles to achieve the right aesthetics. So this is a front view, I look at it from the side, look at it, how it goes with the adjacent tooth, am I following the right labial surface creation, look at from various incisal edges. It is important because sometimes when you are just looking at it straight, it looks good, but when you look at it from an angle, you realize that it's not what you wanted to create. Things like this, you can use highly translucent enamel shades to restore teeth back to their original form, and they work fast. These are fast work. Case like this, now this is a case where you can apply those principles there. You can look at your zenith points, you can look at this is something that I do it on the PPT. I create a line, diagnose the case and see what I'm going to create, where are my mamelons, how will I place my dentin, where are the curvatures, where I'll give the turn and create a three-dimensional effect. And then this is a flowable matrix frame technique that I use. I just take a normal matrix band, a plastic matrix band, put it inside the tooth. From inside, I bring it out, and then I create a flowable matrix. I just create a matrix with a translucent flowable material and just keep it there. So my lingual wall is created. Now it is easy. I can just go and put in my dentin according to dentin placement, enamel. So this is the matrix that you create. And from here, you come to this one, creating normal, nice. And this is again not an high-end aesthetic ceramic composite. It is tetric and ceram, the regular universal nano composite. So you can do good restoration. It's not really necessary to really go in for high-end composites. You can eventually, of course, but if you just apply the principles, you can achieve results which are far, far better. Case like this, she came to me for diastema closure, clearly orthodontic case. Was going to get married, and as you can see, I don't know about that screen, but as you can see, there is a lot of translucent as well as whitish enamel in her. There is a wear on her labial surfaces. So I thought that we'll do it with tetric and IPS Empress, and we look at the side angles, we look at the curvature of the tooth, and I do a mock-up kind of a stuff with a regular material, and then we look at the smile line, we look at the macro aesthetics by doing just the mock-up. Mock-up is also important. This is regular composite mock-up which I send my patients away. They are not bonded. I want to see how their speech will be affected, because what I've noticed, if you are doing diastema closures, patient will always have a speech problem for a few weeks, always. They will not be able to speak better, and you have to counsel them that this will happen, and they have to stay with that for some time, and it will go on its own. And this is the final result that we achieved later on. This is the final result that we achieved in the presentation, in this case, from this diastemas to this one, and she was pretty happy with that. Though I still believe this was an ortho case, she could have done a better job there. Midline diastema, very tricky, and I just don't do it freehand. Midline diastema is something which I use what we call as matrix technique. I take my impressions, I pour the models and do a wax up. So once that wax up is done, we check the wax up lingually, facially, even the incisal edges so that you don't overbuild. And that wax up is duplicated in a rubber-based putty. And that putty is used to create the matrix. So now, as you can see, I have created the matrix with the corrected diastema closure. It's easy. I don't have to do it right there onto the patient and struggle with the shape. Now shape is already done on the models. So I place this. This is the lingual wall created. And now I keep on building it up with my dentin, with my enamel, And that's the diastema closure done predictably using the translucent effect in our materials, and you do not have to do it freehand there. This was a tricky case. Patient is already wearing a PFM, which is highly opacious, and I knew that eventually I'll be able to convince him. This is still not completed, but I'm trying to show you something here. I knew that I'll be able to convince him changing these PFMs into Emax all ceramic crowns, but till then he wanted to do something with his adjacent laterals and canines. In these kind of cases where I'm not very sure how will I match the color, I depend on value and I take a black and white picture. In a black and white picture, as you notice, I'm trying to go to this value because this is the natural tooth, not coming here, to the lower incisors. So we prep it for veneers. We see the color change happening in value. And then I start doing veneers on the lateral. And I'm just focused on matching the value of the laterals with the lower incisors at this moment. Maybe next time when I come here, I'll be able to show you the full case where we'll change the centrals and change the canines, change the lower, and patient will have a better look. But this is a black and white photography, helps you to work with values very, very well. Now, let's come to aesthetic functional. What do you mean by aesthetic functional? You are doing cosmetic fillings, but there is function involved into it. Now I'm looking at fractured teeth and trying to build the whole tooth just by composite. No crowns, nothing. Just the composite. Maybe I'm using post somewhere, but I need to keep function in mind. I need to keep interferences in mind. I need to keep bite in mind. I need to keep axial loading in mind. So that's functional stuff which comes in pretty much. Look at this case. Came with fractured incisor. Root canal treated. So I put a post, use my flowable matrix technique to create the contours. And once the contour with translucent enamel is created, the post is still there and I've created the distal wall, and now I put in my dentine, which is opacious as you can see. Then I start putting down my enamel, translucent enamel, and this is what I give the patient straight away. So there's no crowns. For past probably 3-4 years, I'm not doing crowns, and I just do either full coronal buildups or I do ceramic onlays in posteriors. So this is what we can do. The advantage of this was the now patient wants change of rest of her restoration. So the hard work pays. I just did one tooth knowing that she has faulty restoration, but when she looks at her teeth now, she knows that they all can be corrected to beautiful looking teeth, and that you increase work for yourself. You can do something like this, a diastema closure, and I have done a fiber optic splint and just tetric and ceram build up here. So, finish the case, looks beautiful, and this is there for almost 4.5 years now, doing pretty well. So you can do a lot with composite restoration. As I said, I'm an artist, so I love playing with this material a lot. So from here, you can come to this one. What would you do in a tooth like this? You'll extract it? See, I am also an implantologist. There was a time when I used to extract it and place an implant. When I was my postgraduate years, I was putting metal post in them. Today, I don't do anything like this. I just put in a post, isolate the adjacent teeth, start with my lingual palatal wall with a translucent enamel, and start building the tooth step by step. Dentine, enamel, translucents, build it up completely, finish and polish, and let it be. These are the restorations which have lasted me 3 years, 4 years, 5 years. So they work. It's just that you follow the principles, you apply techniques right, you do the right work, they work, and you are able to create these restorations. Look at the lingual surfaces, the anterior guidance, the cingulum, the fossa, and you can create some good-looking restorations here just by doing composite restoration. This is also just tetric and ceram, a normal, universal composite. Lastly, let's come to functional. Functional is where I'm not looking at aesthetics at all. I'm just looking at bite, eating, chewing, function. And here I use a material which is bulk fill. Now, this past 1.5, 2 years have been a development in composite dentistry about bulk fill materials. Every company has come in with bulk fill. Every bulk fill is the best. So it's up to you to choose which one you want to choose. So I would suggest go through literature, go through a lot of research articles, see which one has probably the lowest shrinkage stress, which one has good strength, which one can give you with their bonding system the better shear bond strength, because these are the things you're looking at when you do work, which I'm trying to show you here. I use bulk fill because of these values. It shows shrinkage stress of probably 1.13 megapascals, which is pretty low, less than 1%. It shows shear value of around 40 megapascals in ideal conditions, but I believe it will be somewhere between 25 to 30, which is enough for occlusal loads and shear strengths. So let's look at some of the cases. There was a time when I was doing this case, post and core crowns, but I always realized that all these premolars, even if I do crowns, eventually fracture down. Patient comes back to me with the crown, tooth inside the crown fractured, and I am at loss. So now I put in a post. So we go in, put in posts, post on both the teeth, and start building them with bulk fill. So this is the first premolar built in. The second premolar, I always create the contour of the tooth first before start to filling it up in. It helps me to contain my field of work and completely fill it up. This is the finished restorations in occlusion. This is nowhere that I'm going to keep them out of occlusion, because I trust and believe that they're not going to fracture down. And if you look at it, this is 1 week post-op, patient in occlusion with these restorations. These are the teeth which are holding her lower dentures. So you can do that. This works very well. And I'll show you, I'll give you scientific data also for this. A case like this, where only a buccal wall, thin buccal wall, palatal wall, lingual wall, root canal treated tooth. If I do a crown prep, I lose the buccal wall completely, which is horrendous. So this is a case which I will simply create my contours and fill it up step by step. It requires only 3 steps with bulk fill, and recontour the whole restoration. Finish from here to here, just doing composite work. This is something which you can do. This is something that you can do predictably. Cases like this, single step restorations, 5 minutes, what you are seeing and what I am seeing. This is single step restorations, just build up with one go. You can cure this material for 4 millimeters. Yesterday in hands-on, I demonstrated that it actually gets cured till 8 millimeters. Don't push that much, 4 millimeters is good enough. All of you who would probably think that he's doing all this stuff, this will not last. This will break down. There will be micro leakage, there will be shrinkage stress, there will be caries, there would be secondary caries. Let me give you some points to ponder. Composite failure, micro leakage did not influence caries lesion formation. Micro leakage does not affect caries development. Narrow gaps, crevices, ditches, micro leakage does not lead to secondary caries. There is enough data. Go on Google, find, there is enough data. This is not true. What is true is the fracture of the restoration. Most of the restoration, obviously, there's another factor, is debonding. I'm assuming that you're bonding it right. If you're bonding it right, it's just the fracture of the restoration. All restorations, all clinical trials have shown that the most common cause of failure has been fracture. Why fracture? Because they were not strong enough. What is composite? It's a resin. It has to polymerize to achieve its full strength. So I come back to curing again. If you don't cure it right, you don't polymerize it completely. If you don't polymerize it completely, you are leaving a weak composite in patient's mouth, which will fracture, and you will see a problem. When it fractures some of the tooth also along with it. When you do posterior restorations, there are some additional points to keep in mind. One is C factor, and the other one is curing depth. C factor is that if you are doing a lot of restoration which is touching a lot of walls, the number of walls it touches is C factor, and if C factor is high, you're going to have a lot of shrinkage stress. So it's better to go from wall to wall than from bottom to top. If you look at the SEM section, you will see the fracture is always in enamel rods. Very rarely it occurs in the restoration if cured properly. The second point is, if you're doing deep fillings, you have to cure for longer time, because your curing strobe light is farther away now at the proximal box base. So if you're curing it for 10 seconds, cure it for 20, 30, over cure is not going to kill you. Under cure is going to make your restorations fail. So if, to summarize it all this work that we see that is there in patient's mouth, posterior, anterior, composite restorations, they are highly successful. We are, all of you who are students here, you are in an era where composites have achieved the ultimate stuff now, whether it's bonding, the kind of composites we have, and we were just looking at the morning session of composite, which is self-etching, self-curing, self-bonding, and that's what probably the future is. The point of caution is that every time we cut down a step, we cut down on bonding strength. That is a fact. Again, scientific fact. See, I'm a scientific kind of a guy. I read articles, I go through research, and I realize that there are some facts, and there is something what we call as dramatization. So every time from my total etch to bond, when I go to self-etch bond, from my self-etch bond when I go to universal bond, and from there when I go to self-bonding composites, I'm cutting down, I'm lowering my bonding strength. So I still use 4th generation where I'm using 3-bottle systems, and I'm getting fantastic results. So in our desire to cut short the time, do it fast, I think we do at times compromise on the quality of the restorations. So with this, I would thank you. I hope it was instructive and helpful and probably enjoyable as it is for me doing this work. Thank you.
Thank you, Dr. Sachin, for your valuable speech. I think all of the audience will be benefited out of your lectures. Thank you once again.
Now question and answer session. Dear audience,